Next, I call upon Dr. MARIAN PAULY. She's a consultant in orbit and oculoplasty and the head at Giridhar Eye Hospital. She'll be talking about when there is rubor, calor, and dolor.
Yeah, thank you, Dr. Soumya, for giving me this opportunity. So I have put 3 pictures in this. Will you treat all these patients in a similar manner? So that's a question. I hope you will be able to answer that question at the end of this talk. So orbital infections can be either bacterial, fungal, tuberculosis, or parasitic. So coming to the stages, group 1 is preceptor cellulitis. This is basically for the postgraduates. Group 2 is orbital cellulitis. Then group 3 subperiosteal abscess. Then group 4 is orbital abscess. And group 5 is cavernous sinus thrombosis. So the clinical onset vary considerably. In any of these stage, patient can present to us. Causes periocular trauma or surgery or spread from a local infection, sinusitis, dental, dacryocystitis. So when you see a patient with a lid edema, suspecting infection, you have to ask a detailed history and or spread from a remote infection. Preceptor cellulitis is anterior to the orbital septum. We can manage it on an outpatient basis. The preferred antibiotic is amoxicillin clavulanic acid. Coming to orbital septum, we know the clinical features. So the main thing is we have to prevent the complications, mainly ocular, that is glaucoma, exposure keratopathy, arterial occlusion, optic neuropathy, panophthalmitis, then intracranial complications, then orbital complications like subperiosteal abscess and orbital abscess. So this is a case of dacryocystitis with the orbital cellulitis and later on abscess. This is the ring enhancing sign in CT scan. Coming to subperiosteal abscess. So in subperiosteal abscess, most of the time pediatrics, they present just with lid edema. Always ask the history of fever. So this child actually presented to her casualty in the morning with the lid edema. The doctor treated as allergy and afternoon she presented like this. So she had subperiosteal abscess. You can see in this the abscess adjacent to the ethmoid sinus. So this is very, very important to identify the subperiosteal abscess. Then coming to the orbital abscess, most of the time eccentric proptosis and imaging is diagnostic. So differential diagnosis can be pseudotumor, thyroid eye disease. You have to rule out all the other inflammatory conditions. Coming to the evaluation, aim is to find the inciting event. History, very, very important. Always check for the other eye examination because we know it can cause cavernous sinus thrombosis. Then routine blood test, blood cultures, poor ill, but still you have to do blood cultures. Then culture of nasal swabs, if any drained abscess, etc. Children less than 9 years, single isolate, staphylococcus, more than 9 years, polymicrobial. Coming to the evaluation, imaging to detect sinus disease, extent of orbital disease, and classify the infectious process. So when will you do CT scan? Worsening clinical picture, decreased color vision, then signs of any CNS complications. MRI if you're suspecting a retained orbital foreign body, especially wooden foreign body. So when you see a patient with orbital cellulitis, the first thing what you should do is check the vision. All the ophthalmic examination was done and then admit the patient. Don't send the patient immediately for CT scan or whatever. Admit the patient, start the patient on intravenous antibiotic. First option will be amoxicillin clavulanic acid or third generation cephalosporin. Then once the first dose of IV antibiotics is over, then you can send the patient for imaging. There are so many instances. Initially, patient was seen in OPD, then sent for CT scan, and the patient comes back with no PL or defective vision. So that we don't want to happen. In penicillin allergy, we can use vancomycin or fluoroquinolone, metronidazole if you are suspecting anaerobes. So monitor the patient every 4 hourly. Remarcate the zone of erythema or induration is the first sign of response to antibiotic. Then continue the treatment for 3 weeks. Add steroids when the patient is afebrile. Surgical management, suspect abscess when there is a progression of clinical signs. This is the high-risk criteria for surgical drainage of subperiosteal abscess, that is age 9 years or older, associated frontal sinusitis, non-medial large subperiosteal abscess, gas within the abscess on CT scan, recurrence after prior surgical intervention, radiological evidence of chronic sinusitis, acute optic nerve or retinal compromise, dental etiology of infection. So this is a case of orbital abscess which we have drained. Coming to chronic infections, TB, rarely we come across, but still you can get, but the presentation is always different. She just presented with a lid edema. Then we have investigated her. You can see her CT scan. This is not very typical of acute infection. This is there are so many other differential diagnoses. So when Mando was 10, Mando was positive. She's actually a non-diabetic, 8 years, a history of fever. And when we ask the history, there's a history of chronic orbital pain also, and he had double vision. She had double vision also. So treated as TB, and she became all right. Fungal infections I'll just touch upon. Aspergillus and mucor are the most common. Aspergillosis seen in immunocompromised and immunocompetent. Treatment is primarily by voriconazole, but it is very expensive, so majority of our patients might not afford. The alternatives are amphotericin B. Then practically we are using itraconazole. So this is a patient who presented to us following with a chronic pain and lid edema. You can see that lid edema. When I was asking the history, she said she underwent some ENT surgery in the past. So when we did the scan, she had a fungal granuloma. It was an aspergillus, and she was treated with itraconazole as she could not afford voriconazole, and she became all right. This is the postoperative resolution of the mucormycosis. So we are all very familiar with mucormycosis treatment because of COVID. Opportunistic infection, diabetic ketoacidosis, inverse and occluded vessel, early sign, early deep pain, rhino-orbital progression. This is very, very important to identify the mucor, because in mucor, the characteristic of lid edema is it is like we have seen AO and pilot disc edema like that. Since the pathology is ischemia, you see edema without inflammation. So management, we can actually, it's a big thing to discuss mucormycosis. There's an article published by Dr. Santosh in IJO. So combined medical and surgical treatment, thorough debridement, correction of the underlying metabolic abnormality, amphotericin B is the preferred. Second line is posaconazole. Fluconazole and voriconazole not very effective. So in chronic retroorbital pain, always look for proptosis and lid edema, suspect chronic infections. Parasites, we commonly see diarrhea, cysticercosis occasionally. Cysticercosis is an anterior orbital involvement, presence with cellulitis like picture, treated with albendazole. So this is a case of a lid edema after 6 days. He presented to us after 5 days. Then we did a scan, showed a cyst with scolex. We have to confirm. We did IgM cysticercus. It was positive. Then treated with albendazole, and he became all right. Diarrhea-filariasis is very common in our part. Always presents with the periorbital cellulitis. Initially, we think it is as infective, but looking at the fleeting lid edema, various characteristics of the lid edema, basically fleeting lid edema, like today edema, tomorrow no edema, like that. Imaging, ultrasound sometimes can help you. Antihelminthic treatment is not very effective, but we have tried ivermectin in our series. Excisional biopsy is diagnostic as well as therapeutic. Coming to the next set of inflammation, next set of lid edema, that is inflammatory, orbital inflammation, can be either specific or non-specific. Specific primarily granulomatous diseases, then the non-specific. So this is a young patient presented to us with lid edema. We can see the nature of the lid edema. It is primarily localized to the lateral orbit. So she had dacryoadenitis. You can see the enlarged lacrimal gland. She had a history of chronic otitis media, for which she underwent biopsy. That was negative for all the diseases. But however, her inflammatory parameters were very high. So we suspected some sort of granulomatous, like GPA, granulomatosis, polyangiitis, or sarcoidosis. We directly went ahead with the biopsy in this case. See the scan, you can see the indentation of the globe with the mass. And it was granulomatosis, polyangiitis, and she did well with rituximab and steroids. So now this is another case of inflammation. So look at the color of the lid edema. So this edema gives you a clue that this is not infective, this is inflammatory. Is it allergy? In allergy, you will get the lower lid involvement also mostly. So then again, look at the ocular examination. You can see some chemosis near the medial conjunctiva. She had medial rectus myositis. All investigations done. It was non-specific, treated with the steroids. So an orbital inflammation takes a good history, because you have to rule out so many systemic diseases, then investigate for any specific cause like GPA, sarcoid, most commonly we see, then tuberculosis also. Steroids first line. Recurrence or inadequate response to steroids, to think about biopsy. rheumatology consultation in chronic recurrences to start immunosuppressants. So this is another case which I would like to share. Is this orbital infection or inflammation? So you can see there is a lymphedema, congestion, chemosis, and you can see restriction of abduction. But the characteristic thing is, it is more commonly seen in slit lamp. There is prominent episcleral vessels. So this is no infection, no inflammation. This is CCF. So you have to be very careful. So orbit is Pandora's box, history taking, clinical examination, radiological assessment, biopsy whenever necessary, and treat according to the cause. Thank you.